Welcome everyone to Rogers Behavioral Health webinar. My name is Genevieve Frazier with Rogers Behavioral. Joining me today is Dr. Marty Franklin and Dr. Rachel Schwartz, and they will be discussing some of their current research on OCD. Before we get started, I'd like to give a shout out to to all the professionals joining us at our watch parties at several of our Wisconsin locations. And I'm going to do a quick overview of today's format. The webinar is scheduled for 90 minutes, and in order to receive CE credit, you must be logged into the webinar for the entire program. Your attendance is going to be tracked via Zoom's login and logout records. A PDF of the PowerPoint, as well as a full list of references, are available on your personal dashboard at ce-go.com. A recording of the webinar will also be available and published on Rogers' YouTube channel as well as our website within the next 1 to 2 days for you to rewatch. And our speakers today will give a 70 to 75 minute presentation. Following the presentation, I will facilitate a question and answer session. During the presentation, please feel free to use the Q&A button at the bottom of the Zoom taskbar. I will review all questions submitted, and please note that I may combine some similar questions as they come in. And finally, we have enabled closed captioning for this program. I will go ahead and turn it over to our presenters.
Rachel and I have nothing to disclose. Apparently, we have no financial or non-financial relationships to speak of. Learning objectives, things we're going to cover in here today. Let's go to the next one. Recent empirical findings is where I'll start, and then I'm going to turn it over to Rachel to do the rest. I will try to hit on some of the implications of the research findings for clinical practice in my piece as well. Okay, next one. This is who we are. Next one. So let's start with the recent empirical findings. Next. I guess sort of recent. This is March of 2024. This paper came out looking at intensive CBT telehealth for ped OCD. And I'm going to be alluding to that. And I know we've discussed some of these in prior webinars. As a sort of a dusting off, I want to talk about these quickly and then get to some of the stuff that's more recent and more pressing. Next one. Some of this we discussed in Philadelphia this past fall as well. We looked at predictors and moderators and some of these medication effects, which we're now breaking down further. We'll be looking at in a lot of detail come this fall and winter. So a quick summary of what do we have about medications, selective serotonin reuptake inhibitors in OCD in general. There's some upside. We certainly know we have many trials showing that the SRIs, the SSRIs are consistently better than fake medicine, which is good. It's going to be better than fake medicine. It is also the case that if you generally maintain your gains if you stay on the med, not everybody, but for the most part. Also that the SSRIs are readily available. The downside is residual impairment. So if you look at the data, you usually get about a 6 to 8 point reduction on a primary OCD measure, which is the Y box or the Psi box, and a 0 to 40 range. So usually you're looking at people coming into the trials at 26 to 28 at pre-treatment. These are clinically impaired folks. If they get a typical medication reduction, which is, again, we're probably looking at 25, 30 different studies, you get a 6 to 8 point reduction in symptoms, which is good. It's better than what you get with fake medicine, which is almost nothing. But the downside is your 20 on average is still going to leave you with clinically significant symptoms and impairment. So that's SRIs alone are not usually enough for everybody. Another downside is there are some people, even at the reasonable doses and durations of med, who don't respond anyway, and some people can't reach those doses because of dose-limiting side effects. So you got a subset of people for whom medication alone is not going to be enough. Relapse upon discontinuation of med, if you stop your med and you don't do anything else, it's likely you'll see a return of symptoms. And with children and adolescents, you've got this black box warning, which is a slight increase in suicidal ideation for people on active medicine versus on placebo. So it leads to some practice implications that we'll talk about as we go. Okay, next one, please. So CBT, cognitive behavioral therapy for obsessive compulsive disorder across the developmental spectrum. Looks like it's efficacious relative to a whole bunch of different control conditions, wait list, medication alone, placebo, other forms of psychotherapy. So it's pretty good. Robust symptom reduction. Remember I said 6 to 8 points on the SI box or the Y box for medication alone? Typically, you're looking at 10 to 15 point reductions for CBT, both alone and in combination with SRI. One thing we've seen very consistently in the combined treatment studies is that the combined treatment doesn't make CBT alone worse. It sometimes makes it better. Sometimes it doesn't make that much difference. There are a couple of exception trials down here. But for the most part, I'd say that they work well together. And the follow-up assessments attest to the durability of treatment gains in CBT alone, which is maybe in contrast to med as well. Downside of cognitive behavioral therapy is treatment refusal. A lot of people don't want to learn how to lean into the situations that provoke anxiety and discomfort. They'd rather go around them. And the treatment for OCD, centrally, exposure plus response prevention, meaning leaning into the things that make you uncomfortable and simultaneously reducing and eliminating rituals and other forms of avoidance. And so not everyone wants to sign up for that. It's also the case, we know, that in most community settings, it's hard to find high quality CBT. A lot of people say they do CBT, but they don't necessarily do it the way that it would be optimal to do from the randomized trials that we've done and all the 30 or 40 or 50 years worth of treatment development we've done. We also know, even if you do it well, treatment response is neither universal nor complete. Looks like there's probably 20, depending on the study, 20 to 30% partial and or non-responders. So we have people who don't take to it both alone and in combination. But we do know another thing that happens a lot is that one barrier to limit access to care is availability of expertise and distance from those clinics. And that's where telehealth, we thought, might be of relevance to bridge those gaps. Next one. In general, telehealth in psychology and psychiatry, 15, 20 years worth of research as a potential avenue for care when access to care is limited. We are very interested for whom it does work, and also really more importantly for whom it doesn't work. Because I think that for some people, you may want to skip the step of telehealth if it's suggested consistently that they're not likely to respond to telehealth. You may need to go in person. Again, interest in these topics for a decade plus, but when the pandemic hit, it sort of forced our hand. Next one. So this is the study I was alluding to before, published in JCAP in March of 2024. We had 1,286 patients with OCD. The biggest sample before this study was published, any published study with kids with OCD, was 269. It was a multi-site study done in Norway, Sweden, and Denmark. So we have 1,286, and that sample size allows us to feel confident about our conclusions and also to look at subgroup analyses in ways that we could never do before. The mean age for our sample was 14.1, a little older than some of the randomized studies that have been done. So it kind of leads you into it being more of a teen sample, and it has some implications we'll talk about as we go. Next one, please. The measures we're going to look at in terms of this presentation, I'm going to look at this continuous SIBOX, Children's Yale-Brown Obsessive Compulsive Scale, and the PQ-LESQ, which is looking at quality of life. Next one. We had entrants come in two different levels of care. One is partial hospitalization, which was the majority of our sample. 6 hours of programming per day, typical stay of 4 to 6 weeks, depending. 3 hours every day of individual CBT blocks at the time. And we also did parent university, group education, et cetera. So it was a milieu, but a lot of focus on cognitive behavioral treatment and within that treatment, exposure plus response prevention. In the intensive outpatient program, it was shorter, 3 hours a day instead of 6, shorter stays typically, and also included those group and education elements that were included in partial. Okay, next one, please. So we look at the continuous data first, just to look at the outcomes. What you see here, effect sizes are highlighted. And what you see is the in-person versus the telehealth. It's the first line, SciBox, 1.5 versus 1.4. Good effect sizes within subjects, effect sizes change pre to post, and comparable, really close. And also you see the same on the PQ-LASQ for the PHP patients. And in an IOP, there's a little bit more of a difference. 1.3 is the effect size for the SciBox in IOP versus 1.0 for telehealth as opposed to in person. Comparable reductions in, or improvements, I guess, a way I put it, in quality of life for both of those as well. Next one. So when you analyze this using the fancy math, the summary of regression analyses and predictors, there were 4 variables that predicted SciBox scores at discharge. And by prediction, I mean regardless of which treatment they got. If you were in telehealth, if you were older, and if you had more comorbid psychiatric diagnoses, your outcomes tended to be a little not as good. And if you had a longer length of stay, they tended to be better. And when it came to predicting quality of life, age and diagnosis count predicted PQ-LASQ scores at discharge, both negatively. So if you were older, your improvement in quality of life was lower. And if you had more diagnoses, your improvement in quality of life was lower at discharge than it was if they were different. On average, though, a really important point, which is telehealth patients discharged with SciBox scores about 1.25 points higher than in IP patients. So a little bit of a difference, but the difference clinically, in terms of clinical meaningfulness, typically Foa et al., this is a study that was done in 2022, had suggested that anything lower than 3-point difference is not clinically meaningful. So we have a statistical difference that's probably not clinically meaningful. And I think that speaks to the utility of telehealth as an alternative. Okay, next one. So we looked at moderators too. Moderators are predicting specific responses to individual treatments. So not just treatment in general, but specific responses to individual treatments. We looked at a bunch of different things. The only one that really came close to popping the way we ran it the first time was a trend suggesting that telehealth might have been more beneficial for girls than for boys in particular. I think there's some things we've got to unpack in there too, because we've also got a difference that is in the base rate of ADHD, for example, is higher in boys than in girls. We might be picking up some of that effect here. We're going to break that down as we go, and we've got lots of different opportunities to do that, which we will take. But in general, it was pretty good. Next one. Telehealth offers a feasible and efficacious alternative to in-person. Again, slightly higher discharge SciBox scores at IOP. We're going to try to break that down, see what other things are predicting responses, better responses to telehealth, or more attenuated responses, the flip side. But in general, I'd say treatment response was robust across all variables. The large-scale test and robust response speaks to the continued use of telehealth as being another viable treatment alternative for us, especially when travel distance and paucity of local expertise limits access to this empirically supported intervention. Next one. So we got interested in this once we went in and started looking at telehealth versus in person. We got interested in these other issues. So we know the black box warnings for youth are out there. They came on in 2004. FDA put those black box warnings on the SSRIs, but yet the data from multiple studies with OCD suggests that SRIs are both safe and effective for use across the developmental spectrum. So the clinical practice guidelines as they exist now, there are a number of different versions of that, recommend combining SRI with CBT when you can find good CBT, especially that focuses on exposure plus response prevention. You're more likely to get a better outcome if you have SRI on top of CBT than if you have SRI alone. But one thing that's interesting is SRI dosing. In OCD has been studied in randomized trials, but not necessarily in naturalistic settings, which leaves us in an interesting spot to think about. We're a naturalistic study, so we didn't control these things. We didn't force people to doses, to medications, to duration. So we have a wider range to look at, which might lead to some interesting discoveries, and that's what we went to next. Next slide. So this is Franklin et al. 2011, published in JAMA. It's what we call the POTS2 study. So these were kids who were already on. They came to us on an optimal dose, sort of at least a therapeutic dose of an SRI. We let the SRIs float, so you could be on any one of them. But most kids, almost 90% of the sample, were on either sertraline or fluvoxamine or Prozac, with the other options. So those are the main ones we're looking at. So optimal dosing, we wanted people to be already in a good spot for whatever you're going to get out of medication you're going to get before we start you. So at baseline, you're on a good dose of medication. You've been on it for at least 12 weeks. And in the POTS2 study, we then randomized people, everybody on medicine, whatever medicine you walked in on, got randomized to just stay on their medicine, or to have a brief CBT added, or to have the full CBT, which was 14 sessions over 12 weeks. And when we ran this study, we were expecting that the brief CBT would do a little better than it wound up doing. Brief CBT did not separate from medication maintenance alone. You get a little bit of a reduction in both of those, but not different from one another. Whereas the full dose CBT separated from both, and the reduction is about what you'd expect, 11 points on the side box. So kids did well. 16 is the clinical cut that would get you into this very study. So if you get below 16, you're doing pretty well. On average, they're 14 and change, which is quite good, encouraging. But again, the combined treatment using the full dose of CBT was better than the other alternatives. So let's look at what we got next. These are just the doses of the medications. Again, we wanted people at a reasonable dose for a reasonable duration for this study. In the study we're looking at now, it floated. We let that, we weren't controlling for that. Okay, next one. So it's a retrospective study. We're looking at the effectiveness of optimizing SRI doses, because we know we're in the position clinically where if a kid comes in on a low dose, we could move them to a higher dose while they're with us. And we use the same dose definitions that were used for POTS2. We thought all the kids, regardless of their medication status, would improve. That's consistently what CBT alone can provide us, what medication plus CBT will provide us. And we thought, though, that being on the higher dose of the SRI, those kids would show more improvement than those who weren't on, either were not on anything or were on a suboptimal dose of SRI. And the IRB approved. These results I'm about to talk about briefly are preliminary. We've got a lot more work to do, which I'll talk about, but I'll show you what we have so far because it's pretty darn interesting. Next one. So we were defining a stay basically as you could be either in PHP or IOP, and if you were with us, 7 to 17 was the age range. Primary diagnosis of OCD, admission and discharge scores available on the side box. Let me get into some more methodologic detail on the next slide. So we looked for people who had a contiguous treatment. So if they were readmitted, it was within 14 days of their encounter. So you might see somebody who was at PHP who got stepped down to IOP. Those if it were within 14 days, those cases were maintained. We had an expert psychiatrist review to determine which cases should be excluded. So cases where the medication dose was still being titrated at the end. The patients were stepping up to residential. We didn't include them because the treatments are so different. They had an illness or other factors that prevented medication from being taken as prescribed. They were excluded from this study. We wanted a nice clean look at what happened. RAs did all this painstaking work to extract medication names and doses from all over the medical chart, the EMR. And then a computer algorithm scored these names and doses to determine optimization status at admission and discharge. And we use regression analyses like we did previously to look at SIBOX and PQLAS-Q scores at discharge as a function of medication status group. Okay, next one. So here are the groups. We had 4 groups that we created. The first group were patients who were not taking an SRI, either at admission or discharge. So essentially CBT alone, 108 kids. We had a group that stayed suboptimized. So they came in either on nothing or on a suboptimal dose of an SRI, and at discharge, they were still on a lower dose of an SRI, in accordance with that POTS 2 study. Then there were 2 other groups. One became optimized, so they came in suboptimal, and we moved them to a therapeutic dose. That was 141 kids. And then there were another group of kids who started out already on what we would classify as a therapeutic dose and maintain that throughout the entire study. Thus far, we have 573 kids. Again, giant study compared to what's out there in the literature. Next one. Some demographics, nothing terribly interesting. The mean age was 13 and a half, so a little bit of a younger adolescent sample. Then they're coming from that other sample, so it's not surprising. Length of stay, number of encounters. So we had a handful of cases in which they were both PHP and IOP, but generally speaking, they were one or the other. And length of stay, again, counting those kids in for multiple encounters, about 60 days with a pretty wide range of length of stay. We'll deal with that later. Next one. Okay, so here's where it gets kind of interesting. The first thing you'll see yourself doing, my head's turning to look at this graph to the right, telling me that everybody seems to be going down, which on the SIBOX is good. Remember what I said about 16 is the clinical cut? All 4 of these groups got below 16. Everybody coming from 24 to 27. So clinically significant OCD at admission, subclinical OCD at discharge, but there's a difference. Look at the gray versus the black. You look at the 2 groups that are gray. They're kids who came in on no medicine or who came in on a medicine and remained suboptimized at the end at discharge, 108 and 166, and they're laying on top of one another. The other 2 groups, one who became optimized and the other stayed optimized, you look at the difference there, and that's 10 versus about a 14 and change. That's clinically significant. So it's not just statistically, but it's also clinically significant. So it looks like becoming optimized or staying optimized is associated with better outcomes. Everybody got better. Let's not lose sight of that. But the optimized groups did better than the sub-optimized and the no med group. Next one. Same trend. Again, black lines running together. The kids who became optimized were doing the best on quality of life improvement, which is interesting. But also those kids who stayed optimized are doing quite well. And there's a difference between those 2 groups and the other groups who were either sub-optimized or had none. Everybody's moving in the right direction, but some are moving there faster than others. Next one. So some upside. It's a naturalistic setting, so we had a larger range to look at. It's a huge sample size, relatively speaking. Standardized CBT protocol was used. We had medical experts looking at the inclusion-exclusion criteria, which helped us kind of really fine-tune this. And medication information was extracted and scored, and we had multiple raters to verify the accuracy of that, which was good. That was a lot of Rachel's work. Thank you, Rachel. And then the downside is it's not a randomized trial, so there's questions you can ask that we can't answer. The medication adherence during the study and medication history prior to coming in wasn't systematically tracked, so there's some questions we can't get at there too. So the results, I mean, these are really sick kids who were at Rogers, so we don't know if these results are going to generalize to traditional outpatient settings, but for the sicker kids with more severity who needed higher levels of care, well, what we found was pretty interesting, and it suggested that the SRI dose matters. Next one. So strong effects across all groups. Patients on the optimal doses, though, did better. And I would say that the clinical trial results, generally speaking, were replicated. It looked like it's good to add CBT, and it's good to add CBT, especially when you're getting those doses up to where we consider therapeutic level. Next one. So we got to finish scoring medication data. We've got to look at these issues of comorbid diagnoses and comorbid diagnosis class, which we'll be doing, and other potential moderators and predictors of efficacy, concomitant other symptoms, those sorts of things. We're looking also at all of, there's a lot of different medications in here too. We tried to clean this, but there's some potential polypharmacy stuff to be looked at here. And whether, to me, examining whether effects differ for each individual SRI, we have enough kids on these meds to suggest we can look at that. And then we're going to conduct similar studies across child adolescent residential patients, which we didn't do here, and also adult patients at PHP, IOP residential. We're starting to do that as well. So a lot of interesting stuff we're going to get at. Next one. Matt Boyer did a lot of work on this thing, looking at these regimens. Many poor souls on the medication scoring side were locked into a dank basement and looking at things until their eyes were falling out of their heads. We thank all of them for that. And the investigative team at Rogers, we've got some outside consultants as well, but this is the core of our group that really is moving us towards making the most of what we can with the data we have. Okay. I think we're good. So I'm handing over.
Okay. So we just saw two examples of how CBT can be modified, first to fit real world settings, and then second, different treatment modalities like telehealth. Now we're going to talk a bit about how it might be adapted for OCD presentations that may be less responsive. So specifically symptoms of OCD that are driven by emotions other than fear and anxiety. OCD had been classified as an anxiety disorder until it was removed from the anxiety disorder family in DSM-5. And that was in keeping with growing recognition that while anxiety is often present in OCD, it isn't always the only or the primary emotion maintaining OCD symptoms. In fact, feared consequences, like fearing a fire without checking the stove or getting an illness without washing hands, those appear to be absent in about half of OCD cases. Instead, rituals are often performed in response to other emotions. And one prominent example is not just right or incompleteness feelings. Here, the goal of ritualizing isn't to prevent some feared outcome, but to achieve a subjective feeling of just rightness or inner completeness. And I know that that's pretty abstract, so I thought we might do a little bit of a demo to make that more concrete. Hopefully this works. Here we go. Okay, so if this exercise worked, you may be sitting with a sort of uncomfortable feeling, not really anxiety, maybe the feeling that the tune isn't complete, just doesn't feel right. Some of you may have already completed the tune yourself just to get rid of that feeling, sort of like doing a compulsion to get rid of the not just right sensation. As it turns out, not just right sensations themselves are universally experienced. We all have them from time to time. Maybe when we see a painting that's hung up a bit crooked and have the urge to fix it. But the difference is that with folks with OCD, these sensations are felt as much more intense, much more disturbing, and much more difficult to suppress. And they prompt urges to ritualize, and the rituals themselves can become extremely time-consuming. As many as 3/4 of OCD patients have significant not just right symptoms, and for up to a third, not just right is the sole presentation. These symptoms can be really debilitating. They're associated with worse OCD severity, comorbidity, functioning, quality of life, and disability. Another emotion that often drives compulsions is disgust. So just broadly speaking, individuals with OCD are both more sensitive and prone to experience disgust than both patients with other anxiety disorders and non-anxious controls. When rituals are performed in response to disgust, once again, the primary concern isn't with preventing feared outcomes, it's just preventing that icky or gross feeling that accompanies not doing compulsions. Disgust exists on a continuum. It often coincides with anxiety and OCD, but it's estimated to be the sole or primary emotional driver of symptoms in about a fifth of cases. So taking a step back, all this means that any single compulsion might have very different emotions underlying it. So take hand washing for an example. Even though hand washing might look more or less identical across patients, designating someone as having washing OCD obscures important differences about why hand washing is done. So even though the what or content of symptoms is the same, the differences in motivations or the whys might have a bearing on treatment planning and outcomes. So for instance, someone might repetitively wash hands due to the fear that if they didn't, they'd get sick. But hand washing might not have anything to do with fear. Someone else might wash hands because they feel compelled to, simply until it feels right. Maybe they're after some just right cleanliness, texture, or temperature. Or simply because it would feel gross or icky if they didn't. And we use the term non-fear-based OCD or NFB OCD to refer to emotional drivers of symptoms other than fear. And not just fright and disgust are two prominent forms of non-fear-based OCD, but certainly other emotions could also play a role. The issue is that exposure plus response prevention, which is a specific form of CBT, that's the first line treatment for OCD, which Marty spoke about a bit earlier in the presentation. ERP was designed to reduce fear and anxiety specifically, with its emphasis on testing and disconfirming feared outcomes, and by leveraging principles of fear extinction, which might not hold so well for emotions that are learned and maybe unlearned differently from fear. We know, for instance, that anxiety habituates or declines naturally over time, and that's often a focus of exposure practice. But evidence suggests that not just right sensations and disgust habituate less overall and more slowly. And also, when you look at standard ERP manuals, you'll see that they really don't provide much guidance at all on how to manage non-fear-based forms of OCD. So in some ways, it's really not surprising at all that emerging evidence suggests that non-fear-based presentations respond worse to standard OCD treatments. The literature overall is limited, but here's a meta-analysis I published that looked at 11 studies representing 530 OCD patients. You can see that not just right symptoms improved only modestly over treatment. So 0.57 is fairly small for an uncontrolled or pre to post treatment effect size. And when we looked just at studies that had control arms, we again saw the same thing, not just right improvement was small. So the literature for disgust is even more limited. Excuse me. But it points to the same conclusion, that disgust is associated with worse ERP response. Excuse me. One study that had 101 adults with OCD found that primary disgust-based OCD was associated with worse outcomes in internet-based CBT. And similarly, a meta-analysis that looked at exposure-based treatments for anxiety and related disorders broadly, where one of the 8 studies included was an OCD study, that found that anxiety showed large reductions in treatment, but disgust improved only modestly. And the story seems to be similar for youth in the one study I'm aware of. And that found that higher levels of disgust and not just right symptoms at baseline predicted worse treatment response. The good news is that tailoring standard ERP therapy to enhance fit with non-fear-based pathology is a promising treatment avenue. The authors of that 2020 meta-analysis on exposure and disgust speculated that maybe disgust showed smaller improvements than anxiety because the treatments that were included in the meta-analysis weren't tailored to disgust. And that was actually a speculation that was borne out in moderation analyses in my meta-analysis on Not Just Right. That showed that treatments that were tailored to Not Just Right produced large improvements in these symptoms, and treatments that weren't tailored offered only little relief. So this suggests that rather than having to scrap existing treatments, the first-line OCD therapy might be modified in precise ways for non-fear-based symptoms. But it's still unclear what tailoring ERP therapy would entail. There aren't any standardized protocols or treatment guidelines. It's also unclear which individual tailoring strategies are helpful and which aren't. And also how aligned academics are with practicing clinicians when it comes to treating this presentation. So we recently conducted a survey study at Rogers Behavioral Health to help bridge these gaps. In this study, 97 mental health providers from a variety of settings completed an online survey assessing their perspectives on using ERP therapy to treat non-fear-based OCD. Clinicians were recruited from different professional listservs and online forums and were eligible to participate as long as they had experience treating OCD with ERP. So many different types of professionals were represented. The aims of the study were to learn, first, what tailoring methods clinicians are actually using for non-fear-based OCD in their work, and whether clinicians are using strategies grounded in empirical literature. We wanted to learn about novel strategies clinicians are using that aren't yet being studied, and also to start to get a sense for how well these methods work. Ultimately, we hope to use this information to inform the development and testing of the first treatment protocol for non-fear-based OCD. So the survey provided descriptions of ERP and both forms of non-fear-based OCD, along with clinical vignettes. And participants were presented with a list of tailoring strategies. There were 22 for Not Just Right, 25 for disgust. Those came from a lit review and our own clinical experiences. So for each strategy, clinicians were asked if they had ever used it, yes or no. And if they had, they were asked to rate the helpfulness of that strategy from 1, not at all helpful, to 4, very helpful. And they did that for adults and separately for youth clients. There were also open-ended strategies, open-ended response items that invited clinicians to describe other tailoring strategies that weren't listed. So just before getting into the results, here's a bit about our sample. As you can see, most clinicians were white and women. Most were master's level therapists or counselors, followed by doctoral level clinical psychologists. And participants belonged almost exclusively to the CBT or third wave CBT orientation. And they were mostly working in private practice or in a psychiatric or other hospital setting. And that was at the outpatient or slightly more intensive level of care. 87% worked with adults, 59% with adolescents, and 37% with kids. We can also see that this was a pretty experienced group in terms of ERP. Almost 3/4 had treated 20 or more OCD cases with ERP, and about 90% reported at least moderate expertise with ERP. The sample was also pretty experienced with non-fear-based presentations of OCD specifically, though here we see a bit more of a spread. So generally speaking, the first thing we found is that clinicians consider ERP to be somewhat to very effective for both Not Just Right and disgust symptoms in OCD. And we're going to start digging into the specific tailoring strategies that we surveyed, how often they were endorsed, so meaning the percentage of clinicians who reported having used that strategy, and then also how helpful each strategy was perceived to be. We're going to start with the strategies rated as least used and helpful, because really the only two strategies that were consistently rated poorly were the only two we hypothesized shouldn't be used. And those were giving up on exposure and giving up on ritual prevention altogether. So these strategies were used by no more than 8% of participants and were rated on average on the lower side of the 1 to 4 helpfulness scale, which I'm always going to include at the bottom as a reference. Do keep in mind for these helpfulness ratings that they were based on only a handful of responses, since so few clinicians endorsed these strategies in particular. But right off the bat, this might be seen as even more evidence in favor of tailoring rather than discarding altogether exposure plus response prevention treatment for non-fear-based forms of OCD. So what might that actually look like? The first set of strategies we asked about in the survey were based on the possibility that principles of fear extinction may not apply as well to symptoms driven by other emotions. So first, given the slower and reduced rate at which not just fright and disgust feelings habituate, it may be that more treatment, whether longer exposure sessions or more sessions overall, might be necessary to achieve desired outcomes. And we did see that both of these strategies were fairly commonly endorsed and rated as at least fairly helpful, particularly extending exposures for disgust in adults, which is in bold. And since we might want to give more weight to the perspective of experts, for all the strategies, we looked at correlations between expertise and perceived helpfulness. And we represent any correlations at least medium in size in the rightmost column. So here, for instance, more expert clinicians tended to rate both of these strategies as more helpful for not just right OCD, that's represented in blue throughout, and extending treatment overall as more helpful for disgust, which is represented in orange. Also, if patients aren't habituating, and maybe we should be expecting heightened states of distress for longer periods of time in non-fear exposures, we might need modifications that enhance tolerability. And that might include more gradually phasing out compulsions or adding certain kinds of distraction or relaxation to exposure. And again, we see that all three of these strategies were fairly common, especially a more gradual approach to ritual prevention. And we're also rated as at least fairly helpful across the board. That said, expertise was negatively correlated with the helpfulness of distraction and relaxation. And this could be an expression of the conventional view that these things, distraction, relaxation, should be avoided in exposure because they might interfere with emotional engagement. We also considered that if not just fright and disgust habituate less, then paradigms that aren't predicated on achieving habituation may have greater relevance. So for instance, we have ACT, acceptance and commitment therapy, that emphasizes that learning to accept and function while in a state of distress should be the focus, as opposed to eliminating this distress through habituation or other means. And then we have inhibitory learning, which suggests that the goal of exposure shouldn't be to extinguish the original associations through habituation, but to form new associations that can compete with or inhibit the original association. If that's the case, then ERP might be modified to de-emphasize within session habituation, as well as emphasize tolerating discomfort, and to incorporate acceptance, mindfulness, and other ACT or inhibitory consistent techniques. And that, again, is tentatively borne out in the high rates of endorsement of these strategies, especially emphasizing toleration of discomfort and additional ACT techniques. And also in their helpfulness ratings, which were especially high for additional ACT and inhibitory learning strategies in adults in bold. And many of these strategies were also considered more helpful by more expert clinicians, which you can see on the right. So separate from the question of habituation is the way in which disgust is learned, and whether that means that extinction principles that are based on fear need to be modified. So we know that fear is learned through Pavlovian conditioning, but disgust is increasingly understood to be learned through something called evaluative conditioning. Evaluative conditioning involves a change in liking or a change in one's attitude towards something. For instance, a once neutral stimulus, say a mop, might take on a negative valence through being repeatedly paired with something that naturally elicits a negative disgust reaction. Let's say being repeatedly used to clean a foul-smelling bathroom situation. Over time, the mop may on its own trigger disgust. Exposure might be brought into better alignment with the evaluative conditioning framework if we were to add positively valenced stimuli that could help alter attitudes. So in other words, adding things to exposure that naturally elicit positive feelings, like relaxation exercises or photos of cute animals. And 3 such strategies have some preliminary evidence from laboratory studies. We have counter conditioning, US reevaluation, and imagery rescripting. So counter conditioning entails repeatedly pairing the once neutral stimulus, in this case, in this example, it's the mop, with a naturally positive stimulus. And some studies have found that counter conditioning with photos of cute animals was able to reduce a learned disgust response, whereas just unpairing, like in standard exposure, was not able to do so. So US reevaluation focuses on the other side of the equation, pairing the naturally disgusting stimulus, like say bodily fluids, with something positive, like new information about why bodily fluids are so important for our health. Imagery rescripting is another strategy that aims to change attitudes, and it does so by altering disgusting images, and those could be physical or mental images, into more positive ones. And this method has also shown some promise in laboratory studies. Excuse me. So in our study, only 8% of clinicians reported having used counter conditioning, but about a fifth had used US reevaluation and imagery rescripting for disgust. And helpfulness ratings were maybe on the lower side, say for imagery rescripting with youth, but they were also based on relatively few responses and were still rated as fairly close to fairly helpful on the whole. A second set of tailoring strategies stems from the possibility that maybe the issue is that non-fear-based symptoms are simply being missed as part of standard ERP. If so, this would suggest the need for more targeted assessment, either informally doing a functional assessment by asking questions that get at the motivations underlying rituals, not just the content. So asking questions like, why do you do this ritual? Or what would happen if you didn't do this ritual? Or you could incorporate validated measures of these constructs. It also might point to the need for more guidance in how to design exposures that actually elicit the appropriate emotion, not just fear or anxiety. And as you can see, informal functional assessment and designing exposures specifically eliciting the emotion were nearly universally endorsed for both not just fright and disgust. And all were rated as helpful by the overall sample and by more expert clinicians, but especially validated measures and designing exposures that elicit the emotion. So shifting the focus of exposure may also mean we need to modify the vehicles of exposure implementation. So the SUD scale and the hierarchy. Modifying the SUD scale may entail dropping the 0 to 100 or 0 to 10 scale in favor of a simpler or different method that's more appropriate. Something maybe even like low, medium, or high difficulty exposures, just as an example. It might require explicitly expanding SUDS from just a narrow focus on anxiety to include other forms of distress or discomfort more generally. Or maybe we want to develop separate scales and anchors for each emotion, a SUD scale for anxiety, a SUD scale for disgust, and so forth. Similarly, it might be useful to create separate hierarchies for fear versus non-fear oriented exposures when multiple emotions are present, which is often the case. So all of these strategies were used fairly commonly in the sample, though it seems maybe like clinicians might prefer expanding one SUD scale to creating multiple scales. And all were rated as at least fairly helpful, though separate SUD scale were again rated as less helpful by more expert clinicians. Meanwhile, we also saw that developing a simpler SUD scale was rated as significantly more helpful for youth and adult clients. So we then wondered which, if any, cognitive targets are relevant in the treatment of non-fear-based OCD. Cognitive interventions aren't really a central component of standard exposure therapy, but exposure is thought to facilitate cognitive change in a few different ways. So first, exposure helps patients test feared outcomes, see their fears are less likely to happen than they believed. But exposure also helps challenge the importance that patients place on thoughts by creating opportunities to see that thoughts don't necessarily have a bearing on what actually happens. In non-fear-based OCD, though, there aren't any feared outcomes to test, as we've talked about. And especially for not just right OCD, which is often described as more of a physical sensation, something like an itch, some wonder whether there are any thoughts to target at all. On the other hand, maybe there is room for cognitive interventions for these presentations, just focused on different areas, maybe reappraising the emotion's meaning. So for not just right, this might entail altering appraisals of the sensation as unbearable or causing uncontrollable discomfort, instead trying to reframe these feelings as false messages from the brain or mismatches between a desired perceptual state and reality that are neither good nor bad and that are tolerable. And for disgust, reappraisal might focus on beliefs about the threat level of objects or bodily sensations that are associated with disgust, or meta beliefs about disgust, or maybe the moral components and feelings of guilt that often coincide with disgust. So we asked about de-emphasizing features of typical ERP that may have less relevance. So namely, testing feared consequences, challenging the importance of thoughts, and imaginal exposure, since that usually involves imagining the worst fear. And all three were endorsed by at least 30% of the sample and were rated as at least fairly helpful. We also asked about putting greater emphasis on cognitive therapy more generally, and specifically for those high in disgust sensitivity. So that's the level of distress that someone experiences in response to disgust. In contrast, some have thought that maybe more behavioral strategies should be used for those high in disgust propensity. In other words, those who are just more likely to experience disgust in a given situation. We also asked about interceptive exposure for disgust, since it might have potential to alter appraisals of the visceral components of disgust. And once again, all of these strategies had relatively high endorsement, and particularly, if not surprisingly, more cognitive therapy for not just right OCD. And all were rated as approximately fairly helpful. Okay. And finally, we also asked about two other not just right or disgust specific strategies. The first one has to do with the similarities between not just right OCD and tics. Oftentimes, the distinction between the two is, admittedly, it does feel a bit blurred. But maybe that means there are insights that we can borrow from the tics world, like using competing responses. That means substituting another behavior for the OCD compulsion, usually something that's similar to or incompatible with the compulsion. For disgust, we've observed in our own clinical work that it might be helpful to encourage patients to refrain from making disgust faces during exposures. So interestingly, more than half of respondents had used competing responses with not just right OCD. And this strategy was rated at middling helpfulness, though significantly more helpful for youth than adults. And discussed incongruent expressions was used by about a quarter of clinicians and rated as similarly helpful, though less so by experts. Okay, so I mentioned that the survey also included open-ended response items probing for tailoring strategies that we didn't list. We had 2 of those kinds of items. So the first one asked about just general strategies, any others that we didn't mention. And the second item asked for modifications that were consistent with inhibitory learning specifically. And so we can see that several themes emerged for not just right. General strategies mentioned more than once included cognitive diffusion, additional values work, DBT skills, and something that reminds me of a technique I've used with panic disorder, sort of noticing and objectively describing the physical sensations associated with the not just right feeling. For inhibitory learning strategies, expectancy violation came up quite often. So in traditional exposure, this typically means highlighting the discrepancy between what one feared would happen versus what actually happened in an exposure. But clinicians here elaborated on other types of discrepancies that can be emphasized to facilitate learning when there aren't any fears. So for instance, what a patient expected their SUDS might be versus what the SUDS actually were, or having a patient reflect on what they expected their ability to be to tolerate the discomfort or to function while in a not just right state versus their actual ability to do so. And relatedly, we saw several mentions of focusing on mastery and the ability to function, and a few mentions of not necessarily going in order of difficulty on the hierarchy. For disgust, we saw a lot of similar themes, emphasizing functioning while uncomfortable, even if that means allowing some accommodations, like doing some compulsions. And this is also mirrored to some extent in the emphasis on patient values. So if we're not trying to achieve habituation, maybe the goal is to get back to functioning and living in accordance with our values. And once again, we see mention of expectancy violation and going out of order on the hierarchy. In terms of takeaways and how we might apply this information, we found that most of the strategies surveyed were fairly common in this fairly expert sample. Even strategies that come from laboratory studies and haven't been tested in real world settings, like US reevaluation and imagery rescripting. And also common were strategies that are typically thought to be contraindicated in exposure, like using competing responses or distraction and relaxation. We also saw that almost all strategies were rated as at least fairly helpful. That is, of course, except for the 2 that we included because we thought that they shouldn't be used, and those were foregoing exposure and ritual prevention altogether. These 2 strategies were rarely implemented and were not found to be particularly helpful. So combined with the general perception of ERP's effectiveness for non-fear-based OCD, this once again supports the view that we don't necessarily need to scrap ERP altogether, but rather we should be looking for ways to make specific modifications to use exposure plus response prevention to treat non-fear-based forms of OCD. In terms of what we might be able to glean about how we might go about making these modifications, what we saw in the survey is that some of the big contenders might not require major overhauls to ERP, maybe just more minor tweaks to the standard protocol, like giving clinicians more guidance on how to develop assessments and exposures that target the appropriate emotional phenomena, or modifying timescale considerations, whether that's by extending sessions or the overall duration of treatment, or by making ritual prevention more gradual. On the other hand, other candidates definitely represent more radical departures from the standard ERP model. So like all those strategies from the previous slide that are typically discouraged in the context of exposure, or even just adding more cognitive therapy, which isn't typically a huge component of exposure plus response prevention. Results also highlight the potential relevance of inhibitory learning. So in line with this model, many clinicians endorsed de-emphasizing within session habituation, along with disconfirming feared consequences. So if the goal of exposure isn't to achieve habituation or to test fears, it does make us wonder what we are supposed to be doing in exposure. And the results of the survey studies suggest that we might instead focus exposures on certain inhibitory learning targets, like helping patients learn to tolerate the discomfort, or highlighting discrepancies in what the patient expected versus what actually happened. And not in terms of feared outcomes, but in terms of SUDS and expected ability to tolerate the discomfort and function. So overall, again, prioritizing the ability to function over not feeling any discomfort whatsoever. Results also highlight the relevance of ACT and related techniques. So the item that specifically asked about ACT and mindfulness was endorsed frequently and considered to be quite helpful. We also saw that many of the novel strategies described were specific examples of ACT techniques like cognitive diffusion and values work. And so once again, this speaks to what we can and maybe should be focusing on during exposure, if not habituation or testing fears. And that is that we can help clients learn how to get back to their values in living life, all while accepting some amount of discomfort. So this research generated a list of potential tailoring strategies that OCD clinicians, many of whom were experts, use and consider helpful, including several novel strategies that weren't on our radar. But none of these strategies have been systematically tested in clinical trials, so we can't say that they're evidence-based for non-fear-based OCD. This work does set the stage for a planned program of research that seeks to develop the first treatment protocol for non-fear-based OCD, which will integrate and test these strategies. Let's do a quick time check. I think I have some time to go through a case example. I thought it might be helpful to go through an example of how I applied some of these tailoring strategies with a patient with significant not just right symptoms. So this patient was a cis white man in his early 40s, working full-time and married with a young child. You can see here that in addition to OCD, he was also diagnosed with social anxiety and Tourette's. So one of the first orders of business in this case was to differentiate which symptoms were not just right rituals and which were tics. Making that distinction was challenging. In general, I'd say that the patient felt that his not just right rituals were somewhat more controllable and repetitive than tics. So as is often the case with not just right OCD, just about anything could trigger not just right feelings for this patient. But just to offer a smattering of examples, a big set of triggers were things that you could open and close or turn on and off. So light switches, faucets, doors, or shower curtains. And this would lead to repetitive attempts to turn off and on, or say the sink, and often using more force than we would otherwise, all in an attempt to get at a just right feeling. And that could take upwards of 10 minutes every time this patient used the sink or the light switches and so forth. And it often led to bruising. Other triggers included disruptions in routines and certain types of mess or disorganization, leading to repetitive attempts to do things like, let's say, fold his son's blanket just right. This case also illustrates that not just right sensations happen across sensory modalities. So in addition to these like tactile and visual not just right cues that we just went over, there were certain auditory phrases that would trigger these sensations for this patient. So hearing things like bye-bye instead of goodbye. His rituals were done simply to get at that incomplete or not just right feeling. This patient denied that there were any feared consequences associated with not doing these rituals. And unlike other patients I've worked with, he really only had not just right symptoms. He didn't also have OCD symptoms that were driven more so by anxiety and fear, or disgust for that matter. So here's a sampling from the patient's exposure hierarchy. When constructing the hierarchy, we immediately ran into difficulty using the 0 to 100 or even 0 to 10 SUD scale. The patient just had a much easier time categorizing exposure exercises as relatively easy, medium, or hard. You can also see that exposures were specifically designed to use the patient's triggers to elicit not just right feelings. And often that meant approaching a trigger like a light switch and having the patient interact with it in a way that felt incomplete, like just using it once. So exposures were about making things wrong on purpose. But then what? So we did have the patient sit with the discomfort and make every attempt not to ritualize. But unlike with anxiety exposures, the goal wasn't to lean in. We weren't trying to get the feeling up as much as possible so that it could naturally habituate. Instead, we framed habituation as more of a bonus. If it happened, awesome. But that's not what we should expect or what we were aiming for. Instead, the focus was to encourage the patient to tolerate the discomfort while resisting the urge to ritualize, and to test the extent to which he could function while feeling not just right. We found that simply sitting with the feeling, sort of like focusing on an itch that you can't scratch, that wasn't necessarily the best way of going about that. So we experimented. We experimented with what could help him resist the urge to ritualize, what else he could be doing while feeling not just right. Could he complete any chores he'd be meaning to do? Could he successfully distract himself by telling me his plans for the weekend, or by naming objects of all the colors in the rainbow in the room? We also tried deep breathing and other grounding and relaxation exercises. So really any amount of triggering that not just right feeling without giving into the urge to ritualize was considered a success, and sort of framed as the metaphor we kept returning to was strengthening a muscle that would make future exposures easier. Another thing we tried for some of the most resistant or hard to overcome rituals was introducing competing responses. So those are the things that patients can do in place of rituals that are physically incompatible. Again, this comes from the tics and Tourette's world, habit reversal therapy. So here are some examples. Just as an example, just to highlight one example in particular, when he wanted to turn a bye-bye he heard into goodbye, this patient tried clearing his throat instead. Usually in OCD, I'm sure many of you know that we don't typically introduce new behaviors because there's a concern that those behaviors could turn into rituals themselves. This was all in the spirit of experimenting with ways to like chip away at highly established ritualized behaviors by any means we could. So we were willing to see what would happen. And for this patient, at least, he found these competing responses to be helpful without becoming rituals themselves. I also did more formal cognitive therapy with this patient than I usually do in ERP, based on the observation that when the patient was feeling irritable or stressed, it was much harder for him to resist not just right urges. So we did some work catching and checking automatic thoughts that contributed to irritability. In this example, the patient reframed a thought about his wife's intentions when she said bye-bye instead of goodbye. And ultimately that lowered his irritability. Excuse me. I think that brings us to the Q&A section.
Wonderful. Thank you so much, Dr. Schwartz and Dr. Franklin. So now is time for the question and answer session. Please feel free to use the Q&A tab there at the bottom of your taskbar to submit any questions. We'll try and answer as many as we have time left in the program today. If we don't get to your question or you would like to ask a question offline, you can send an email message afterwards to webinars@rogersbh.org and we will follow up with you. So one of the first questions was about telehealth. When you say telehealth, was this meeting with a live person who individualizes the treatment for each client, or participating in a webinar style course or group presentations on CBT topics?
I would say it's the first one of those options. The only difference between what was happening in telehealth versus whether it was in person was the modality. So I think there's another question is whether, like, at what point can you make these things more generic? Can you make them, I guess, non-tailored, if you will? And my suspicion is when you start doing that, you're going to start to see attenuated outcome. It may be helpful for a handful of people, but not as many, because I think Rachel's onto something here. I think that the tailoring idea, not just right, but for whatever presentation you're dealing with, you've got to be able to be flexible in the moment. And if you're not in the moment, then you can't be flexible. But I think that, to me, this is about whether telehealth can be useful in providing the same treatment that we do anyway. The difference is just whether you're sitting in the room. That's what we were testing.
Thank you. Have you noticed any overlap between NFB OCD and autism spectrum disorder OCD comorbid presentations?
Oh, we're turning to me.
If you don't mind, Dr. Franklin.
That's fine. Yeah, I think there certainly would be irritability, discomfort, if you will, probably a higher base rate of that in the ASD population, which probably means some of these tailoring methods are going to be all the more important. And I think that when you're treating anybody with ASD, whether or not they have feared consequences or they don't, you have to look at the whole treatment through those lenses. Like, how is this going to come across? This instruction, these suggestions, this advice to somebody with versus without ASD. So everything you've got to do in these treatments is going to need to come through there. My suspicion is you would be looking at higher base rates of no, I mean, I don't have great data on this, but I think you'd be looking at higher base rates of non-fear-based OCD in that population. And that may have something to do with the capacity to articulate about emotion. So it's kind of a more basic function that seems to be compromised in ASD. So I wouldn't be surprised to see that. When you see it, though, I think the strategies of tailoring versus not tailoring and changing your messaging become all the more important. But you've got to consider, how am I going to get this information across to this person in light of the fact that they have ASD? That tailoring has to happen as well.
Thank you. I have heard that SSRIs are more effective for OCD in higher doses than when used for depression or anxiety. Have there been any studies regarding medication dose and effectiveness?
I would say that there have been, and the biggest problem with those studies is their sample sizes. So the really good study John Grice did maybe 30 years ago, looking at dose response curves in adult OCD. Didn't find much, but his sample size is probably too small. And the sample size that we have now, I think we may be picking up on some of these things because we have more people. And mathematically, when you have more people, you have a greater capacity to find these patterns and to feel confident that these patterns are not just something that wouldn't occur in another sample that was also similarly small. So I think in general, certainly the psychiatrists that I know and trust would say that I'm usually trying to push to the higher doses in OCD compared to depression. I don't think the randomized evidence is fabulous or fantastic. I guess a question we can look at is whether we see that effect in our OCD patients who have comorbid depression. So we might be able to get at that in this sample. Generally speaking, I think our findings thus far would suggest that getting patients to a therapeutic dose, to an optimized dose, call it what you will, if they can tolerate it, is probably going to give you a better chance of optimal outcome. And so I think that this is another piece of that puzzle. And again, this is one study, even though it's a large study, it's not definitive. We have to continue to look at that both within Rogers and outside of Rogers. And I think research efforts need to be redoubled to look at these issues, because clinically, it would be very nice to know when a patient walks in and they've got comorbid depression, they've got very high SIBOC scores at pretreatment. Do I need to put this kid on a med before I even start CBT? And if I do put them on a med, what's my target dose depending on what symptoms I'm targeting? That would be really useful information for practicing clinicians, and that's why we're chasing this down.
Several questions here coming in about medications specifically. So one is, there's a program in my area that tells clients that medications can be a form of avoidance in OCD, and the effectiveness of CBT and ERP is better. They can just do this without medication. Is there any real evidence of this?
I said it earlier. I said what we consistently see, and we're talking about 40 years of randomized controlled trials, 40. And in ped-OCD, we're talking about 20, 25. There's almost no evidence from randomized trials that CBT alone is better than combined treatment. There's more evidence moving in the direction of saying CBT plus medication is better, certainly than SSRI alone. In some cases, they're better than CBT alone. My suspicion is that that's a more nuanced issue. For example, if I have a kid comes into my clinic with comorbid anxiety and comorbid depression and a SIBOX of 30, and again, you can't get at this without large sample sizes. My suspicion clinically is this might be a kid I want to consider a pharmacotherapy consult on up front. So they're very severe, they're very impaired, they've got 3 disorders, not 1. That's a kid who just clinically, and based on what I've seen, I'd be considering a med instead. If I have a kid whose SIBOX is 20, they're mildly impaired, and if I could go without medicine, I might with a kid like that. But the preponderance of evidence cuts in the direction of an advantage for combined treatment, not in every study, but an advantage for combined treatment rather than a detriment. I've seen no study saying combined treatment makes it worse. None. Doesn't mean in an individual case that you might see a kid does better off their med than they do on. But to me, research is about creating a capacity for educated guesses. And the more research you've got, the more educated your guess is. It doesn't give you a guaranteed outcome. Nothing does. There's nothing in this world that's guaranteed. But what I would say is if I've got 40 years worth of randomized trials suggesting one thing, that's going to grab my attention more than a possibility, or sometimes it's even patient preference. I'd rather not be on the medicine. And my answer would be, you're going to choose ultimately what you're going to do. But here's what the evidence tells us. And then people are left to make their own choices. I remain a fan of science despite the current zeitgeist.
Thank you, Dr. Franklin. Shifting gears a little bit, where do moral fears fall in the fear-based, non-fear-based spectrum? Since they are not typically something that can be confronted or disconfirmed in an ERP setting, or would this be considered part of the disgust category?
I did mention the moral component of disgust, so I wonder if this question relates to that piece. And I'd be happy to talk a little bit more about that or expand on that piece. So I guess there are 2 ways where the way that I think about guilt and the moral component coming up when it comes to disgust OCD. The first is simply having the belief that if I feel disgust, that must mean something about the moral quality of the thing that I feel disgusted about. So that's something that we commonly see, that it's not just a self-contained feeling, disgust. It can start to generalize a little bit or take on different forms. It's in other words, a meta belief about disgust. what does it mean that I feel disgusted? It must mean that there's something morally wrong with this object that I feel disgusted about or disgust towards. And so there we have a place where we can intervene, right? We can take a look and say, okay, well, what do we know about that particular object? Like make the case for and against its moral quality. And that's how we can sort of intervene using more formal cognitive interventions on that one. And I think there's also another sense where guilt and morality come into play with disgust. And that is that we know that OCD leads to it leads to guilt. There's like a big link between the two, likely due to inflated responsibility, like beliefs about one's own responsibility. And then guilt also gives rise to the feeling of disgust. Usually that is more self-directed, self-focused. And so some have thought, well, why don't we just intervene, if on the guilt itself? If OCD leads to guilt, guilt leads to disgust, then maybe we can intervene on the guilt piece, the inflated beliefs about one's responsibility piece, and that can help diminish the association between OCD and disgust. I hope that answers that question.
I think it does. And there's another piece here that I think it seems like there's an overlap between disgust and anxiety as driving motives. Are there any good questions that you would ask the client to really differentiate between the two?
Between disgust and anxiety?
Mm-hmm. As motives.
Yeah, I don't, not to be too overly simplistic, but I found the simpler the question, the more effective it is at getting at this particular distinction. In other words, if someone were coming in and saying they were washing their hands repetitively, simply asking them, why do you wash your hands? Like, what is the reason you wash your hands? Or if they can't fully answer that question, what would happen if you didn't wash your hands, right? That kind of gets at, again, the motivation, the why that's driving the ritual. And we're not just living on the surface level where all we're talking about is the content and the what of the symptom. We want to understand the why. Is there a fear? If not, what is the emotion? Is it disgust? If I didn't wash my hands, to use the example from earlier, I would just feel icky. I would just feel gross. There is no feared consequence. It's also possible someone might say, I just have to, or else it won't feel right. And it is also very possible that someone would say some combination of those emotions. It's not necessarily one or the other. Someone might say, I wash my hands because I'm both anxious that if I didn't, I would get sick. And if I didn't, I would feel gross and icky. And I think it's important to identify both of those as important emotional drivers of that symptom that need to be targeted in treatment.
Thank you. A question for Dr. Franklin. I've enjoyed some of your analogies you use with children during the OCD treatment process. For example, the story of Sisyphus when discussing the importance of not undoing an exposure. Do you have any other favorite analogies that you use with children during the course of treatment that you'd like to share?
I'd say I have many of them, and it depends on the kid. And I got into trouble once where I was interviewing a 12-year-old girl at intake, and I was trying to get at some of the tricks. What metaphors, what ways of explaining are going to help this kid? And it turns out she was a pretty accomplished soccer goalie. And so I got very interested in that. So I started asking her questions about how she plays and, shooters who are left-footed versus right-footed. So I'm having a genuinely detailed conversation about her strategy as a goalie. Mom looks at me. Mom had a very expensive watch. Mom looks at me and she taps the watch and does this. Like, in other words, why are you talking about soccer? You're wasting my valuable time here. I thought you were going to talk about treatment. And I was a veteran clinician at that point. So I looked at Mom, I smile, I go like this, I go, and turn back and continue to talk to the kid. What I found in that discussion were the metaphors I needed to use with that kid. So later on in the treatment, when I'm setting up the treatment, we set it up. We had like soccer stuff on our hierarchy, and we had all sorts of ways of talking about it that had to do with soccer. And at the end of the treatment, I give mom credit for this. She said, "I need to apologize to you because in session 1, I had no idea what you were doing. I didn't realize that you were creating the very language for the treatment when you were asking about soccer. I thought you were just asking about soccer." And my response, I appreciate the apology, but keep in mind, it's never about soccer. Never. Even soccer is not about soccer. And then I left her with that Zen koan, like confused again. But my point is, you're going to find the language to drive this treatment and the metaphors to drive this treatment by listening really carefully to the kid. I have a bunch I use. I have a bunch of things I recommend. OCD is like my dog. Well, if the kid doesn't like dogs, I'm leaving my dog out of it. The kid doesn't like sports. I mean, I have many sports analogies I'm delighted to share. But if the kid says, I hate sports, so what do you like? Well, I like theater. Cool. Who are your favorite playwrights? What kind of stuff do you like? And then they get into that, and I'm going to find it there rather than in what I came with. And the more, I think it's about tailoring. It gets back to Rachel's point, which is you've got to be able to do this in real time on your feet. Now I'm going to use a sports analogy. You walk to the line of scrimmage as a quarterback. I'm expecting them to be in this particular defense, and I realize the free safety is not where he's supposed to be. So I know bloody well the free safety is blitzing. He's closer to the line than he should be. As a quarterback, I have to change my play immediately to account for him. And I've practiced that, but in real time, I'm going to make that choice rather than in some film room, because the film room is not enough. So I think that you prepare to use whatever the hell you need to use, and you're going to find out what you need to use by listening to the kid and by finding out the excruciating details of what it is I'm trying to do. Consequence or no consequence, not just right or not or otherwise.
Wonderful. Well, thank you both, Dr. Franklin and Dr. Schwartz. That is all the time that we have questions for today. Remember, if I did not get to your question, please feel free to send an email to webinars@rogersbh.org, and we will follow up. We will also have a recording of this presentation up on our YouTube and our resources page on our website within the next couple of days. Before we conclude, I'll ask for the presenters to share just a couple of high-level takeaways on where you can find resources. Perfect. And that about wraps it up, everybody. Thank you so much for joining us today. Within the next 30 minutes, you will receive an email with a link to your personal dashboard at ce.go, where you can access your PDFs of the PowerPoint as well as the full list of references. Those can be printed as well. And for those of you who did meet the time requirements today to be eligible for your CE credits, you will also use that link to complete your evaluation for today. And then you can download your certificate at any time from your personal dashboard thereafter. If you do have any questions about the CE-Go platform, please feel free to send an email at support@ce-go.com. Our community liaison team is excited to connect with you further about the resources and options that we have for Rogers here, that we have here at Rogers for treatment. And we are excited to continue to partner and serve you and your communities going forward. Thank you so much, everybody, for joining us today. We will see you next time.